Our guest is a very special kind of scientist. She has a conscience. She's a biomathematician, and she had a great deal of experience in modeling AIDS. So she is a biomathematician, and she's an expert in AIDS research. And I'm going to let her tell her own story in a few minutes. Are you on, Rebecca?
Yes, I am. Thank you.
Welcome. Rebecca, I first learned of you when Dr. Harvey Bayali sent me an email and said, check this link out. And I read a monograph by you, an essay by you, and it made my heart sing. It was so beautifully written. And I also felt it was quite courageous because most scientists today won't speak up and rock the boat. Would you tell us about what led you to write that essay and what that essay was about briefly?
Well, the essay was called Why I Quit HIV, and basically it was just a personal expression of the many reasons why I could no longer continue to support the HIV/AIDS paradigm. I had worked on mathematical modeling of HIV infection on an immunological level inside the body for almost 10 years, and over the time that I worked on it, the more I realized that this theory was not answering all the questions, and we were going in the wrong direction, just, keeping our research locked into this one narrow channel of investigation. And I wrote that essay in frustration one night, to be honest, and I didn't expect it to go very far at all. And I got in touch with Harvey, and that was how it got onto the LouRockwell.com website and managed to reach a lot more people than I ever expected that it would.
Where is this website?
LouRockwell.com.
And where were you working as a modeler of HIV infection?
Well, I'm an assistant professor of mathematics, and so the mathematical modeling that I do is just a small part of my job. The bulk of what I did was in my PhD thesis and to a lesser extent in my master's thesis when I was a graduate student. That was where I wrote most of the material that I've published in that field. Right now, I'm an assistant professor, so my research, and specifically my research into mathematical modeling, is a small part of my job. So it's not like I quit my whole job. I think there was a bit of confusion about that. I just simply chose to leave this one area of research.
And you certainly opened up a bag of tricks, or Pandora's box, when suddenly credible scientist was raising these issues. When Peter Duesberg first spoke out, I had been a critic of the model for a number of years, 5 years before I ever heard his name.
Mm-hmm.
And when he first spoke out, I thought to myself, this will be over tomorrow because he's such a prominent and eminent scientist. And immediately he was marginalized, and he was put in a situation where all his brilliance disappeared. The minute he made this challenge and published that paper. And then I've watched a number of scientists come forward on a continuous basis, including Kerry Mullis, a Nobel Prize winner. You would think, oh my, it would make a real big difference. And, of course, a president of South Africa, and you think this will finally do it. And so I'm reluctant to get that excited about anything new that comes along. It's been up and down. You think, oh my, finally people are going to at least look at this issue or pay attention to it. But it seems to me that your particular area of expertise really, really demands people pay attention, because this affects every policy that comes into play, doesn't it?
Yes, it does. And I have gotten some attention. It's been a mixed bag. Some of it's been quite positive, but some of it has been extremely negative. And I see that the tactics that people use, they're very similar. No matter who comes along, there's some sort of way that people try to discredit you, I guess. And I think that the reason that people, I don't know,
accept the theory?
Not so much accept the theory. The reason the theory stays in place, it's some sort of strange combination of apathy on the part of the average person and the incredible financial and sociological motivations on the parts of the people that are promoting this theory.
Could you explain what your career does, what you do? Like, what does it mean to construct mathematical models of HIV? We have a lot of people listening in who probably are saying, what does that mean to construct models of HIV infection? Could you give it in sort of as simply layman terms as you can?
Sure, I can do that. Basically, what I do, or what I've done, is construct systems of differential equations, and that shouldn't sound so scary as it is. All they are is just simply mathematical constructs that are supposed to predict what's going to happen to a particular system at some point in the future based on what we can observe happening now. And in my case, I'm looking at cellular interactions between different components of the immune system. So, for example, the T4 cells, the T8 cells, infected cells, healthy cells, that sort of thing. And you want to see what happens to the populations of those cells in the long term, given that infection proceeds in a particular way that, that you presume from the biology is happening. And what you're looking for is what sorts of parameters determine how fast a person will progress to illness, whether that can be prevented by external means, by perturbing the system, be it with some sort of immunological boost or with a drug, and just basically to make some kind of prediction as to what's going to happen to this person and how long it's going to take.
And how did you do this, in a laboratory?
Well, most of it is done on the computer, actually. The models are constructed theoretically using data that comes from medical laboratories or molecular biologists.
So let me bring up a very touchy subject within what's called the dissident movement. And there are many, many thousands of people who are questioning HIV, and there seems to be this Duisbergian view that HIV has been properly isolated, and then there are other scientists like the Perth Group or Stefan Lanka who say, no, it's never been properly isolated. Etienne also says that it was never isolated, and I was just curious, have you had a chance to look at that issue, and do you have an opinion?
I have looked at that issue, and basically all I can say about it is that, okay, I'm not an expert in electron micrography. I can't say that word.
Microscopy, I think, yeah.
We
both of us can't say it.
I'm not the world's expert in virus isolation. What I understand is that there is a procedure that has been set forth or put forth as early as the 1970s for isolation of a retrovirus, and my understanding is that HIV has not fulfilled the requirements of that procedure. Now, what that means as to its existence as an exogenous infectious agent, I don't know. I will say, though, that without actually properly following a procedure that's been set forth, there are bound to be all sorts of problems that are going to result from that, especially when it comes to determining the specificity of antibody tests and that sort of thing. So if indeed this has not been accomplished, and I haven't seen any evidence that it has been, this has all sorts of profound implications for the accuracy of a lot of things, a lot of qualities and things that have been determined about this virus.
One of the things that tells me that it hasn't been properly purified is that I had access to the actual package inserts from the manufacturers of these tests. And all of them have a disclaimer that more or less says our test is not proof of infection. And it seems to me that that's a really, really important statement for people to see before they take the test. Because how can you make an informed decision when you're told you're infected and the makers of the test say, well, we don't have a standard?
Well, absolutely, and it's even more profound in the case of HIV because I would argue that there's no other medical test that exists that can have such a profound effect on people's lives if they test positive. You know, people don't have their children taken away from them because they have a high cholesterol level, and people don't commit suicide over other medical tests. This is something that concerns me, especially with the CDC's push toward making testing universal, is that this psychological component has either not been taken into account or it's been ignored.
I believe it has been ignored. Sorry to interrupt you.
Oh, that's okay.
I also think it's diabolical for another reason. Because I believe that when you go out and test people who are not at risk, almost all of the results will be false positives, even if you believe that HIV doesn't cause AIDS. But if you extended it and said it does, let's say, okay, HIV does cause it, would be a bad idea. Because we know that there's going to be a terribly high rate of false positives in people with no risks.
Yes, this is absolutely true, and I agree with you that even if HIV causes AIDS, this testing should not be made universal. It should not be made mandatory, and at the very least, people should be informed of how unreliable the tests are because of the amazing implications that it has on people's lives. These test results are used to discriminate against people, and to my mind, it's unconscionable that they're used in this way, and especially when the information is kept from the people taking the test, which it is. People don't know that these disclaimers exist. I've talked to people who have been HIV positive for years and have only found out about the dissident movement recently, and they had no idea what viral load was actually measuring and no idea that the antibody tests were not standardized, and some people didn't even know that it was antibodies they were being tested for. And these are people who've received a diagnosis.
And there's even something more startling. In 1989, I became a New York State certified HIV counselor. And this was put on, it was paid for by the CDC, which funded the New York AIDS Institute. And it was like a 7-day training, as I remember. And during the questions and answers, I raised a question, and I said, I'm concerned because my understanding was that if you test positive for an antibody test, that's not evidence of an active infection or an acute infection. That's testing for a prior infection. And the person conducting the class said, yes, that's true, but if we tell people they have a prior infection, they won't behave. They won't change behavior. And this is a public health initiative. Mm-hmm. So here you have public health officials intentionally lying that everyone's at risk, when that clearly is not the truth. When I first heard, I thought to myself, well, maybe they know more than I do. But then I saw in this insanity, in this mass hypnosis, they weren't only acting on that, they were actually treating these people as if they were infected. Mm-hmm. And I saw the horror firsthand of what happens when you take a healthy person and give them these terrible treatments.
When they were healthy, perfectly healthy.
It's not it's not a good thing if you're sick, but it might be life-saving in certain rare situations. But to give a healthy person, based on this bogus test, these deadly chemotherapies, it's criminal in my opinion.
I just wanted to ask Rebecca a question.
Mm-hmm.
In your article, Why I Quit HIV, you state that you gradually underwent a dramatic shift from thinking HIV was the HIV/AIDS paradigm, and after analyzing the mathematical models of HIV, you realized that, you say you found them virtually to be unrealistic.
Mm-hmm.
And could you explain what you meant by that?
Well, the answer to that is there's really more than one part to that. There are two ways in which the models I found were unrealistic. The one had to do with the assumptions that were used to construct them, and the other had to do with how they were being used to make predictions. Now, I had to learn an awful lot of the molecular biology of HIV before I could even be satisfied with myself, to construct a decent model, and that involved working with medical doctors and talking to biologists and doing an awful lot of reading. And one of the things that surprised me the most was the fact that AIDS is supposed to be caused by this massive depletion of T cells, and there was absolutely no consensus on how these T cells were being killed. And I looked at some early models, and it assumed they were being killed directly. I believe that was what Bob Gallo had assumed, and this was later shown not to be the case. And there were theories about apoptosis, which I think is probably the theory that still has the most support in the biology world. But
so apoptosis, they think that these cells are killing themselves?
They think that they're programmed to kill themselves at a later date, that somehow HIV imparts a kiss of death to these cells.
It's a lie.
Well, I mean, it's ridiculous. Apoptosis happens. If you read some of the Perth Group's papers, they're wonderful at providing literature reviews, and one of the things that is made abundantly clear is that the medical literature indicates that if you take these uninfected cell cultures and stimulate them in exactly the way as you stimulate infected cell cultures, then they're going to show apoptosis as well. So clearly cells are dying. I mean, according to apoptosis, whatever that actually means, they're dying for some other reason. And in the lab, this is, kind of an artificial situation because the antibody response is not there to neutralize anything that might be happening. But it's all highly hypothetical.
May I ask you a question?
Yes.
It seems to me, if you go back historically, the claim that the T cells were being killed and this was making people sick was suspect because at the time, early in what was called GRID, gay-related immune deficiency, scientists readily admitted they didn't know if the low T cells were a cause or an effect. Mm-hmm. And as things moved along, it became very clear that they were an effect. Mm-hmm. In my groups, we had thousands and thousands of people, tens of thousands of people, who, according to the surrogate marker T cell, should have been sick and dying, who were healthy as horses. And then we saw people who had T cells in the so-called healthy range develop TB and die over a weekend. Mm-hmm. So it became very obvious that this wasn't a reliable surrogate market. And then you have the Concord study, which showed that it was a useless surrogate market in terms of predicting things, which brings me back to what you were talking about in modeling. It seems to me a scientific principle is when you put through a workable theory, that allows you to make predictions. And in this case, you say you couldn't make predictions. Doesn't that suggest there's something very wrong with your theory?
Yes, it does. And mathematical models of HIV have long been accepted to be quite poor. And the difference between somebody like me and somebody on the orthodox side would be that somebody on the orthodox side would say, well, we simply just don't understand how the immune system works, and so it's impossible to model. And I would say we're modeling the wrong thing. But it's interesting that you should mention the T-cell depletion being an effect and not a cause, because if you really look at the literature and you look at what AIDS is really defined to be, there's clearly something going on that's not quite a standard immune deficiency, because people who have AIDS are subject to fungal infections and other things like that, and not very much at all to bacterial infections. And what's happening is that the T-cell pool is being shifted from the cellular to the humoral immune response. I'm sure you've heard about this. And so what's happening is they're only measuring one subset of the T-cells, and they're not seeing that the other subset of the T-cells is actually working just fine. And so there's something clearly going on here that's not being measured and can't have anything to do with the virus.
You earlier talked about the stress of being told you're positive. You stop eating, you stop sleeping, you stop taking care of yourself. You lose your energy for the future. You feel like a leper.
Cut off your friendships.
And here you have a situation where T cells migrate under stress.
Mm-hmm.
So
Absolutely.
they leave your blood and go into your skin because they think you're going to be attacked, or they go into your organs to protect you in case of an attack. So you can't count them in the peripheral blood, but they're there. Then you talk about, they claim that there's massive T-cell death. Well, when you have a small wound, you cut yourself, you bruise yourself, you see some pus, those are the white cells that are dead being pushed out of the system. They're talking about, millions and millions of dead cells. Where are they? I have never seen any evidence that there are any dead cells.
Mm-hmm.
It just seems to me that they wanted to create an industry, and they were very successful at that. I mean, they've created a multi-billion-dollar industry, and they wanted to change behavior. And one of the questions I want to ask you as a scientist is, my background is I'm a medical hypnotist. And I believe that a lot of what's going on involves a kind of mass hypnosis. I don't think the average scientist is necessarily corrupt. I don't believe the average medical doctor treating AIDS is a cold-blooded murderer. But it just seems to me that there's some kind of protective mechanism so they don't see what they're doing. And I just wonder what you think of that.
Well, I'm sure that is the case in some sense. When you think about it, the idea of this random indiscriminate infectious agent suddenly jumping from, chimpanzees to humans and going to New York and San Francisco and Los Angeles and exploding throughout the population, it's absurd. And for such a, science fiction-y sort of thing, it's amazing how quickly the public accepted it. And I remember being there when that press conference came on television. I remember watching it. I was 10 years old, and my mother had had a few blood transfusions in the early 80s, and I can remember the fear that she and my father had when they heard about this new infectious agent that was in the blood supply and being transmitted sexually and from mother to child. And I remember just noticing how quickly people accepted this. It was almost like this hypothesis fills some sort of a sociological need.
Can you quote your article, what you experienced as a teenager or a young lady worrying about contracting HIV?
Well, I mean, like anybody else in my generation, I grew up basically under the shadow of AIDS. My experience as an adolescent and a young adult was very different than it would have been for somebody even 10 years older than me, or even, I would argue, somebody 10 years younger than me, because a lot of the panic had subsided by then. And, I can remember feeling at one point, I think I was 21, that I had put myself at risk and, being certain that I had somehow contracted HIV and was soon going to get AIDS and die. And so I took myself to the doctor and begged for an HIV test. And actually, my doctor was... She was a very calm and rational woman, and she didn't want to give me the test, which I think is very unusual. She told me that I was very unlikely to, I wasn't in a risk group, I wasn't likely to have contracted it, but she did give it to me, and I remember kind of filing that away and thinking, I've escaped death. And I know so many other people in my generation have had that same experience.
So knowing what you know now, it's kind of sexual terrorism.
Oh, absolutely, yes.
When I was growing up, I'm a little older than you. I was 35 when they made the announcement, and I remember it vividly. Also, I was paying very close attention. When I was growing up, this was still a sex-negative culture. Mm-hmm. And having sex before a certain age led to insanity, blindness, whatever. But no one said it would kill you. And I think of a generation, and now we're moving into a second generation, that are taught sex equals death. And you just wonder how someone gets around that to have a healthy sexual life. I mean, it's got to be back there somewhere.
Well, we have the study you were talking about last week. Which was that study?
The Pattian?
The Pattian study proves that there is no sexual transmission of HIV. Dr. Roberto Giraldo, I'm sure you're familiar with, also published papers in the late 90s after studying this for 20 years, he has stated that there is no way that you transmit AIDS, or as they call it, HIV/AIDS, through sexual transmission. It is a lie.
I began to question it in the 80s, right after they introduced widespread testing. And in our group, we had a safe, anonymous environment where people could come in and just talk about anything, and that's what we were offering, an information exchange. We didn't feel that we wanted to tell anyone what to think, and I still don't. I just want people to think and look at the evidence and know there is evidence that needs to be looked at. But we had a lot of couples, and they were what's called discordant. One member of the couple was positive, one was negative. And I noticed that never changed.
Mm-hmm.
And another thing I noticed was that the bottom, or the receptive partner, was the one that was always positive or sick. And it occurred to me that something was wrong with that picture, or to put it in a mathematician model, it didn't add up.
Mm-hmm.
And I wonder if you can comment on that.
It's certainly not a sexually transmitted disease in the traditional sense of the word, and study after study, not just the Pattian paper, have shown that these so-called transmission rates are so incredibly low. I think they're at most 1 in 1,000.
Not even. They're non-statistical.
Yeah, well, for female to male, they're much lower than that, but they're so low that something like that would fall below, what's called the statistical noise floor, where people who are, and what I mean by that is people who are very close to one another, living together, sexually involved with one another, they're likely to be sharing certain environmental factors.
So if one is using drugs, the other is likely to be using drugs.
Well, sure, and a lot of these factors are quite likely to influence whether one person would show positive on a non-specific test anyways. So there's really no way of knowing exactly what's being transmitted here at all in most cases.
I'm sorry, there is no litmus test for all of this. It's all vagaries.
In terms of just basic math, could you explain what positive predictive value is? Because this relates very, very powerfully to this question you talked about, widespread testing. The CDC wants to make HIV testing routine.
Sure. The positive predictive value of a test is just what proportion of positive results are in fact going to be true positives. And so if you have a positive predictive value of 90%, then that means that out of 10 positive results, only one will be a false positive. The other 9 will actually be positive for whatever the agent is that you're testing for.
9 out of 10 will be false positives.
If your positive predictive value is 90%, then 9 out of 10 will be true positives. 1 out of 10 will be false positives. The problem with HIV, of course, is that the positive predictive value is much lower than that. Let me give an example. I think, let's say that the prevalence in the population is 1 in 250, it's something like that. So that's 4 out of 1,000 people are true positive, if there is such a thing as true positive. Okay, so if a test is 95% specific, that means that 19 out of 20 of the positive results they pick up are going to be true positives, and the other 5 will be false. But when you go and you apply that in a population where the prevalence is low, you're going to get many more false positives than true positives out of the population that you're testing.
And they want to bring these tests primarily to non-risk populations.
Yes, and I think that the positive predictive value of the tests in low-risk populations have been calculated to be less than 10%. And so less than 10% would mean that fewer than 1 out of 10 people is a true positive.
So that's what I meant. When I said 9 out of 10, I was talking about within non-risk populations.
Okay.
Right? So 9 out of 10 would be a false positive in that group.
If the positive predictive value is 10%, then that is the case, yes.
That's kind of frightening, isn't it?
Yes, it is. And the lower the prevalence, the lower the positive predictive value is going to be. So as you get into the non-risk categories, the number of false positives are going to overwhelm the number of true positives.
So that means the tests should never, ever be routine or universal?
No, and I would argue that they should not be used for diagnosis within the risk groups either, because there's still going to be a number of false positives there. And as we've discussed before, we don't know what we're testing for.
Well, so even if we wanted to be responsible and say we're not sure, because the big argument is, what if you're wrong, Michael? What if you're wrong? So if we administered these tests and said, well, they're presumptive, and if a person tests positive, at least in terms of public health, presume and don't have unprotected sex. And that's what I would have said in the 80s, in the late 80s. But since then, I've become aware that latex is dangerous. And I've become aware that tens of thousands of medical professionals, dentists, hygienists, doctors, nurses, have developed very, very serious allergic reactions, in some cases life-threatening, career-ending.
From latex.
Mm-hmm.
From latex. And this is topical latex gloves on your hands. The exact same latex that is used in condoms, and here for certain partners it's internal.
Mm-hmm.
And it has a lot of friction.
Mm-hmm.
So it seems to me, and when I say this, I'm a menace to public health, but it seems to me in this instance, playing it safe could be the most dangerous thing a person does.
Mm-hmm. Well, I think that it's ridiculous to say that somebody's being a menace to public health when all they're doing is providing information.
I appreciate it.
People are able to make up their own minds. I give most people, a fair amount of credit for being intelligent and being able to detect whenever somebody is saying something that's junk. And all you can do is take the information and decide for yourself.
So I have a question that I would appreciate a mathematician's input on. And this is something that's troubled me since the beginning of the crisis, and they announced HIV and they announced public health measures. And this is that they keep saying that the people who are at the greatest risk have multiple partners. And when I think about that, it seems to me if I had a partner who was infected and I didn't know it, and I repeatedly had sex with that partner, wouldn't my risk, an intelligent person, expected to be far greater than if I had single encounters with a lot of different people?
Yes.
So I'm not crazy to suggest that that makes sense.
No, it makes sense. If somebody is in an exclusive relationship with somebody who has a particular infection, they are at probabilistically greater risk of contracting that infection. I think that the implicit assumption people are making when they say this is that if you are monogamous, then you've probably, checked your partner out and you've made sure that they're not infected. And whereas if you're going out and having multiple partners, then you don't know, and you might be selecting from a pool of high-risk people. But again, this goes back to what we were talking about before, that I think you made a really good point. Most of this is about behavior control and not about health at all.
I, like you and Michael as well, maybe not Michael, but most people in the 80s, in their teens or 20s, feared, like you said, kissing, toilet bowls, anything that was associated with an exchange of body fluids or blood or any of that. We all had fear, and I remember saying to myself a few times, damn it, I missed the sex, I missed the revolution, I came into this, and here I am now, what am I going to do? I'm not going to enjoy my life. But then in my late 20s and 30s, I realized that that's a bunch of bull, and this is a fraud. And Michael, after hearing him on the radio like 10 years ago, and Gary Null, and reading Duesberg, and reading Carrie Mullis and Roberto Giraldo, after about 10 years, I realized that I can do whatever the heck I want. I'm not going to not enjoy my life, because this is a false fraud that has been perpetrated on the world by the pharmaceutical industry and the medical industry. So
actually, it's by public health officials.
Right, exactly.
And
so
these people are just, profiteering.
I just want to interrupt you and say we have a caller on the line. We have a caller, Michelle. Are you on the line with us?
Yes, I am. You're talking about these tests that, and I understand that they were trying to make them,
routine.
Routine. Thank you. But you're talking about HIV or HIV/AIDS. I know, Adam, you just said HIV/AIDS as they term it. And in this article I was reading, and they talk about HIV and AIDS. So my question, I guess I was leading to is when you're talking about this infection, I know, Rebecca, you keep talking about a partner with an infection, and you're talking about in a general sense. You're not being specific, correct?
Mm-hmm. Yes.
But where you're talking about these tests and these results and the false positives and the false and the negatives and whatnot, are we talking about HIV? Or are we talking about AIDS itself? I mean, what's the differential? How do you determine?
There is no test for AIDS, and
say
testing positive does not give any predictive value. You don't know what a person's actual health is simply because they've tested positive, which should make people suspicious about the value of the test in the first place. But the Centers for Disease Control has intentionally really blurred the lines between testing positive and having AIDS. And they joined the two so that you can't possibly think or talk about one without the other.
Can't escape it.
And this is part of, I think, the mass hypnosis. One, you're testing for an alleged pathogen that has never been proved to cause damage, and the other has been so misrepresented that over 2/3 of the cases of AIDS today are people who don't actually have any AIDS diseases. So they intentionally misrepresented. What would you say?
Well, can I just add one thing to what you just said? And then
anytime you want, jump right in.
Yeah, no, I just wanted what you just said. So what is it that, I know you're saying that the HIV doesn't cause AIDS or AIDS is separate, but what is it that they are concluding that with these positive results? If that question makes sense, what is it that?
Sorry, could I give you a little bit of just a brief background into the history of these tests? The tests themselves are not detecting the presence of any virus at all. They're detecting the presence of antibodies. I believe that there are 10 of them that are supposed to specifically react with components of HIV. Now, when the tests were developed, they were not actually developed for diagnosis, and most of them are still not approved for diagnosis. They were developed to screen the blood supply. And so they were made to pick up quite a lot of antibodies, and that seems to be what's happening. Every single one of these antibodies has been shown to react in cases where HIV is not present, and so none of them is specific. And so what they're doing is they're indirectly testing for the presence of a virus, and they're using something that's really, really over-specific. And the reason that they did that in the first place actually made some sort of logical sense when it came to protecting the blood supply, because they didn't know what they were dealing with, and they wanted to make absolutely sure that they screened out anything that could potentially be dangerous. But the problem is that the tests haven't improved much since then, and they haven't gotten any more specific. So at best what they're measuring is people who have elevated levels of certain antibodies.
Which would be evidence of an overactive immune system rather than a deficiency, wouldn't it?
Well, it's certainly a measure of the overactivity of the humoral branch of the immune system, which produces antibodies and also helps to fight bacterial infections, which again goes back to what we were talking about before, where I was saying that AIDS is not a traditional immune deficiency, because actually one part of the immune system is overactive and another part seems to be underactive, and the part that's overactive is the part that's producing antibodies.
As a mathematician, I was wondering what Rebecca thought about this sexual terrorism about today's teenagers. I've been reading in the last couple of weeks, as they try to push for it, that teenagers are at high risk. And it just occurs to me that teenagers are more than likely having sex with each other. And
Yes.
They're probably having sex for the first time. So where is this mythology that they're infected coming from? And how can they make the claim that this is such a fast-growing, high-risk group?
It's pure propaganda. Michelle, Thank you for the call.
Yes, thank you, Michelle. How would you answer that?
Well, like you said, I think a lot of it is propaganda. They're trying to scare people. I don't know how to put it more simply than that. I mean, as you pointed out, it's absurd to think that all of these teenagers could be getting infected, because if you look at the transmission probabilities and then you look at the pool of people that they're interacting with, it's just not very believable.
So if you're not having sex with someone in a high-risk group, and you gave a number, 1 in 250 people in risk groups are said to be infected. Is that correct?
Well, I think that's in the general population.
Okay. Because my understanding is that if you were a non-drug using sexually active person, and there were, it might be something like 1 in 250, and then it would take, according to them, 1,000 contacts. So then you would have to times that by 1 in 250. Is that right? And then it would be like 1 in 250,000.
I think it's dangerous when we start using these numbers that way, because, first of all, like we've said, the antibody tests, we don't know what they mean, and so, it takes 1,000 contacts. Well, what does that really mean? It's one of those kinds of amorphous things that doesn't have any relation to real life, but what you can say from looking at those numbers is that the probabilities are astronomically low. From a single encounter that somebody would get infected. And I think it tells us something, that the few people who claim that this has happened to them, the most famous case being from the 80s, Allison Gertz, we know their names. That's how rare they are.
And we have every reason to know that people lie about sex. This is true too. This is a young woman who was in very dangerous situations, and suddenly no one's to blame because she had one sexual encounter.
Mm-hmm.
And the AZT killed her.
And,
well, that's certainly true.
Yeah, that would be my opinion as well. People lie about sex. People lie about drug use. That's never factored in. And the way they ever came up with this heterosexual transmission is that they gave people a questionnaire. Are you gay? No. Well, it has to be heterosexually transmitted. Are you a drug user? Who the heck in his right mind would say yes?
Well,
They're illegal.
This is another reason we have to take these numbers with a grain of salt. They're highly subjective. All we can say, you can look logically at what is happening. This is not spreading. The prevalence in the United States is exactly the same as it was in 1985. The population distribution, in the country among risk groups is exactly the same. Nothing's changed. This is not behaving like an infectious agent. And when you look at what's claimed to be happening in Africa, that there's this massive heterosexual transmission, I don't know why more people don't open their eyes and say, okay, this is completely ridiculous. How can a virus be incredibly transmissible on one continent and not on another? I don't understand why more people don't look at that disparity and
I think
really
it's because of the prejudice. I think it's because, unfortunately, people in our culture kind of believe that these Africans are wild sexually and irresponsible and reckless sexually. So it kind of fits that image suddenly that they have more sex. The average gay man who came down with AIDS, the first 41 cases, had on average 2,000 different sexual partners a year. That's mind-blowing. And they want us to believe that, it's exploding sexually in Africa because they have all of this insane types of sex with dead monkeys.
But the thing is, that was not an indication of the gay community as a whole.
Of course not.
Mm-hmm.
The gay community lived their life just as any heterosexual family were living their lives, and the subset was that group of gay men that were doing the drugs and having those 2,000 sexual partners a year, coming down with all sorts of infections that had nothing to do with being gay.
One of the AIDS critics, Michael Baumgartner, made a comment once that blew me away. He said that after he started checking statistics, he realized that the average gay man probably was more likely to be killed by lung cancer than AIDS.
Mm-hmm.
And you think, I've never seen ACT UP protesting the dangers of, lung cancer or heart disease.
Well, they want funding.
Thank you so much for being with us. I hope down the road we can do this again. You were an exciting, wonderful guest, and thanks for having the courage to speak out.
Well, thank you very much for talking to me today.
Well, thank you, Dr. Culshaw. And where can people read this article again?
It is on LouRockwell.com in the archives, but a better place to find it is at the AIDS Wiki, and the address for that is reviewingaids.org/awiki, and that's spelled AWIKI. You can get all sorts of great information there, and there is a link on the main page to my article, as well as great articles by Neville Hodgkinson and the
David
First Group
Resnick.
and Peter Duesberg, all sorts of people like that.